24-year-old woman has 2 weeks of strong-smelling vaginal discharge. She has no dysuria or dyspareunia. She has no postcoital bleeding. She has a pink, smooth, non-tender cervix. There is white, watery discharge. And you can see this in the picture on the right. Investigations. Microscopy, there is clue cells present, stippled vaginal epithelial cells. Which is the most appropriate management? A. Acyclovir, 400 milligrams 3 times daily. B. Azithromycin, 1 gram single dose. C. Ceftriaxone, 500 milligrams IM, plus azithromycin, 1 gram oral. D. Erythromycin, 500 milligrams 4 times daily for 7 days. E. Metronidazole, 400 milligrams twice daily for 7 days. I'll give you 20 to 30 seconds to have a think. Pause the webinar if you need longer. As we can see, the answer to question 7 is E. Metronidazole, 400 milligrams twice daily for 7 days. This question required you to identify the condition, which was bacterial vaginosis, and the correct treatment. In the next few slides, we'll go through why this was the correct answer. So we'll be discussing bacterial vaginosis. This is also known as BV. This refers to an overgrowth of bacteria in the vagina, specifically anaerobic bacteria. It is not a sexually transmitted infection. It is caused by a loss of the lactobacilli, the friendly bacteria in the vagina. BV can increase the risk of a woman developing sexually transmitted infections. Lactobacilli are the main component of the healthy vaginal bacterial flora. These bacteria produce lactic acid that keeps the vaginal pH low, under 4.5. The acidic environment prevents other bacteria from overgrowing. When there are reduced numbers of lactobacilli in the vagina, the pH rises. This more alkaline environment enables anaerobic bacteria to multiply. A very common example of this is Gardnerella vaginalis. The standard presenting feature of BV is a fishy-smelling, watery grey or white vaginal discharge, as we saw in the last question. However, half of women with BV are asymptomatic. In regards to investigations, vaginal pH can be tested using a swab and pH paper. The normal pH is 3.5 to 4.5. BV occurs with a pH above 4.5. A standard charcoal swab can also be taken for microscopy. BV gives clue cells on microscopy. Clue cells are epithelial cells from the cervix that have bacteria stuck inside them, usually Gardnerella vaginalis. As we can see from the points we've discussed, Ammel's criteria summarises this, and this is how we can diagnose BV. If 3 of 4 points are present, including a thin white discharge, clue cells, vaginal pH over 4.5, and a positive whiff test. Management of bacterial vaginosis. So if a woman is asymptomatic, treatment is not typically required. However, if a woman is symptomatic, the treatment is oral metronidazole, 400 milligrams BD for 5 to 7 days. Management in women who are pregnant. If pregnant, there is an increased risk of preterm labour, low birth weight, and chorioamnionitis. If the pregnant woman is asymptomatic, it's important to discuss this with their obstetrician if treatment is required. If the pregnant woman is symptomatic, advise that she should reduce exposure to contributing factors such as smoking, vaginal douching, and the use of antiseptic bubble baths or shampoos in the bath.
Also, if symptomatic, the treatment is oral metronidazole 400 milligrams twice a day for 5 to 7 days.
Complications of BV. Women with BV are at an increased risk of acquiring sexually transmitted infections, so it's always important in consultations to screen for all infections. Also, recurrence of BV is very common, and it may be up to 23% at 1 month after treatment. We also get very concerned about obstetric complications, such as preterm labour and delivery, premature rupture of membranes, miscarriage, low birth weight for the baby, postpartum endometritis, post-caesarean section delivery wound infections, and in general post-surgical infections.